Hello, this is Dr. Sodolol, and today I'm going to talk about acute rhinosinusitis and the symptoms, physical exam, and the important points. We are going to talk about the management in a different video. So, rhinosinusitis. In the past, people were calling this disease as only sinusitis. So, this is the paranasal sinuses of the face. And these are maxillary sinus, frontal, ethmoidal, and sphenoidal. So in the past, people were only referring as this disease as the sinusitis. However, in the recent years, it is understood that the inflammation of sinuses usually and most commonly occur with the inflammation of the nasal cavity. And then they coined the term of rhinosinusitis. This is the nasal cavity. And this is an infectious disease which has a different etiologies. The first one that we're going to talk about is the acute viral rhinosinusitis. This constitutes the majority of the cases, up to 90% of the cases, sometimes more. Acute bacterial rhinosinusitis, this only accounts for 0.5 to 2% of the cases. So the traditional method of giving antibiotics to sinusitis symptoms, 98% of the time it doesn't work. So it's not right to give antibiotics to people with rhinosinusitis right away. There are some conditions that we should give, but we're going to talk about it in a different video. And there is the acute fungal rhinosinusitis, and this occurs really rarely, and most commonly this occurs in immunosuppressive patients, like people with malignancy or people with people using medications which are immunosuppressants, like transplant patients. All right, so the bacterial rhinosinusitis has a couple of different microbiologic etiologies, but most commonly it is caused by Streptococcus pneumonia, Moraxella catarrhalis, Haemophilus influenza, and Staph aureus, but most commonly strep pneumonia. So now we are going to talk about the physical exam and what should we look to in the exam of these patients. Let me clear here. Okay, so when a patient comes at you with symptoms suggestive of rhinosinusitis, you should look for any kind of erythema or edema in the face around the sinuses, any nasal obstruction. It can be unilateral or bilateral. Facial pain. If the patient has facial pain elicited by our percussion or palpation, or pressure, or fullness. If the patient has purulent or non-purulent drainage, either from the nose or from the pharynx, the posterior pharynx. So there's something that people really give way more importance than it should be, and this is the facial pain or pressure with the exacerbation of facial pain or pressure with the physician's percussion or palpation of the sinuses, or when the patient or there's another traditional way. You ask patient to bend forward or to lean forward, and if the pain is exacerbated again. So if this is positive, if this occurs, people usually think that it is definitely sinusitis. However, this is wrong, and there are some studies that found that there is no validated study about this. So we don't know its sensitivity or specificity, and this cannot diagnose a patient with sinusitis if it's positive, and this cannot rule out, which is, I think, a more common mistake. People, the physicians can try to do this exam, and if there is no facial pain elicited by palpation of the sinuses, they just rule out. It cannot be done. You cannot rule out sinusitis if there is no facial pain when the patient leans forward or when the physician applies palpation to it. So yeah, these are the most common symptoms, sorry, most common physical exam findings that they are, and I want to talk about the symptoms and the review of symptoms that we should do when we think about the sinusitis. So there are a couple symptoms. So the person can say there's discharge with discolored discharge, for example, green. There is nasal congestion. I cannot smell, so osmia, hyposmia, or anosmia, nasal congestion. The patient can say that I have a headache, most commonly frontal headache. They can say we have fever, ear pain, facial pain or fullness, ear pain, dental pain, or they say I have malaise, we have fatigue, malaise. These are the most common symptoms that the rhinosinusitis patients have. So when we are looking at these symptoms, make sure to think about it critically when trying to understand if the patient has sinusitis or a different diagnosis, such as acute otitis media, tonsillitis. So the patient may have cough. Cough is also a symptom, or throat pain. So if the patient has mostly cough and no nasal congestion, no purulent discharge, no ear pain or facial fullness, it should give us the impression that it is a bit of a upper respiratory tract or a lower respiratory tract infection, and especially if the patient has throat pain. If the patient has only ear pain and some fever and some headache, maybe we can think about something like acute otitis media or Eustachian tube dysfunction. Okay, so if the patient, for example, has dental pain with fever and headache and none of the other symptoms, I think we can think about the process in the oral cavity, for example, an infected tooth or something in the something related to oral cavity, but not the sinuses. Therefore, we should critically think about the symptoms, and review of symptoms is very important, in my opinion, as important as, sometimes even more important than the physical exam. And we have to ask the patient about each symptom, and we should try to understand where the disease is located. Okay, So there are a couple of different symptomatologies that occur in viral and bacterial sinusitis, so to speak. So there are really interesting aspects of the symptom, if it's getting better or worsening, about sinusitis, which may help us to understand if it is viral or bacterial. So what is this guy trying to talk about? So viral, acute, so acute viral rhinosinusitis. This usually, the symptoms peak at the day 3. So the patient comes at you, he has some fever, headache, looks awful, okay, at day 3, but usually gets better at the end of the first week. However, it might not in 25% of patients. This is not true. Okay? And in acute bacterial rhinosinusitis, there are 2 very important aspects of the symptomatology. First one is that it almost always persists more than 10 days, whereas acute viral almost always persists less than 10 days. And the second, and the thing that I find most interesting here, that you can maybe make a difference from your peers, is that acute bacterial rhinosinusitis has symptomatology as something called double worsening. So it starts bad, as all the rhinosinusitis patients. It starts bad, and then it gets better. The patient will think, okay, maybe I am getting better. But near the end of 10 days, it gets bad again. So it worsens at first, and it then worsens again, and it is called double worsening. And this is one of the typical things that we see in acute bacterial rhinosinusitis. The patient may say, "Oh, I was feeling better, but now I am feeling really bad again." Yeah, that's really interesting. That's double worsening. So there are a couple of also symptoms that may lead us to think, okay, this may be bacterial more than viral, and I should be more careful. For example, very high fever. Fever more than 39 Celsius degrees, or more than, I guess, 102 Fahrenheit. I'm not really good at Fahrenheit. I usually use Celsius. I hope this is correct. Or a very bad clinical condition. For example, the patient is feeling really, really bad, cannot perform daily activities, cannot even come to the doctor, calls an ambulance. This usually occurs in bacterial rhinosinusitis. However, this, like the presence of fever, the presence of purulent nasal discharge, or the presence of facial pain, either alone or being elicited when the physician palpates it, does not, so these symptoms do not separate viral from bacterial, and this is a really important thing. So most oftentimes patients will come, my nasal discharge is really green, it looks purulent, I have bacterial disease, or I have fever, 38 degrees Celsius fever, I have bacterial disease, or I have really bad facial pain. These do not separate it from bacterial from the viral. And this is really important because there's a really popular thing among the physicians nowadays about prescribing antibiotics to all sinusitis patients, but 60 to 80% of the prescriptions are wrong. in the patients with sinusitis. So we have to identify which patient is more likely bacterial or viral, but we're going to talk about the management in the next video. Therefore, some people opt to have some imaging studies in patients with sinusitis. Maybe a more senior doctor once did and deducted that the patient has a bacterial sinusitis, or someone told, or some he read from, or she read from somewhere else. So this is not right. Imaging studies should not be done to look if the patient has viral or a bacterial etiology. This is costly, unnecessary intervention in a patient. This should not be done. Okay, why? Because there aren't really definitive radiologic signs that differs viral from bacterial, and they should be reserved for orbital or intracranial complications of sinusitis. So what I'm talking about. So do not obtain plain radiographs of the face, or the head, like Waters imagings, or the head CTs in patients, but reserve them for the patients with possible complications. So what are the possible complications we should technically import? So the complications. So there are some complications that need urgent intervention and urgent referring. For example, if you're a family physician, or if your friend has sinusitis, there are a couple of symptoms that you should ask, and if they have those symptoms, you should just refer them urgently to an emergency department or an otolaryngology clinic. So the first one is the orbital pathologies, the preseptal, or as known as periorbital cellulitis, and the orbital cellulitis. So these two are really important, and the orbital cellulitis is the more urgent one, and the sinuses are really close to the orbital part of the face, therefore the infection can spread temporally. So how to differentiate them? So this is the infection of periorbital tissue, and this is the infection of orbital tissue, and both have eye pain, headache. However, orbital cellulitis has also diplopia, proptosis, the bulging of eyes to the forward, and pain with eye movements. So if the patient also has those symptoms, you should just refer them to an urgent care center or an emergency service immediately, and they will obtain the CT, the CAT scans of orbits and face and the sinuses, and they will be admitted immediately and started on intravenous antibiotics. The second one is meningitis or intracranial abscess, which both of them are really in similar presentation, and both may have headache, altered mental status, neck stiffness, nausea, vomiting, and you should be really careful in these patients. So if the patient looks septic, your sinusitis patient, make sure that you perform a neck stiffness test, okay? And maybe you can also do a mental status exam. This also goes for the last complication that I want to mention, septic, cavernous sinus thrombosis. And this really is something that is not really easy to diagnose, but and sometimes it can sometimes it needs MRI of the head to understand, but contrast enhanced CT imaging protocols should also show that if the patient has this one. And also the symptoms are really similar to intracranial abscess or meningitis, but more likely it will the symptoms will more localize to the cranial nerves that pass from the cavernous sinuses. So in the end, we try to talk about the symptomatology, physical exam, the etiology, and the complications of the acute rhinosinusitis. We are going to talk about chronic rhinosinusitis in a different video, and the next video it's going to be about the management of rhinosinusitis. By the way, the management is really important, and maybe this will be another place that you can make use to separate yourself from your peers, and even in a simple looking disease like sinusitis has a really interesting treatment algorithm which you may not heard, or if you heard, it's always nice to listen again. And thanks for watching. I hope you guys enjoyed my first video. This was my first video. I'm sure that I will improve myself in the further videos. This was Dr. Sodol, and thanks for listening.